Well, I'm just so touched that you've all come here today to listen to my ramblings. I can't tell you how thrilled I am to be at Imperial. I really mean that. A number of people have said to me, why have you done this? This is an odd move for you to have taken. But all my working life, I've backed people. It's not a bad place to start. I happen to think that Aradazi is a very talented man. And we share some things in common, not least mad optimism, a belief in the absolute impossible, and an utter commitment to improving outcomes for patients, which has driven my career for the last 12 years. I'm tremendously bad at politics. I just don't do it. I just put my snowplow on and I knock over anything that looks like a political impediment to achieving outcomes for patients. And I've acquired something of a name for that, but I try to do it in a charming way. I was told that I should read by one of you C.P. Snow's book, The Masters, which describes just how difficult it is to work in university, which can, I'm told, sometimes have its challenges, but I've chosen not to read that book. So, I thought I'd talk to you briefly today about the subject of a good life at the end of life and why doesn't it always happen. And I hope to give you some idea of the way I'd like to work here at the Institute. Ara did mention just now that about the change that I persuaded the Chancellor of the Exchequer to make. And I've always worked that way. You've got to try, I'm a great believer in never seeking glory yourself. Always find it for other people, and in that way you will achieve serious outcomes. So I always describe myself at Marie Curie as the highest paid secretary in the team, and that's the way I'm going to operate here. I want to make Imperial truly great, even greater than it is already. And one of the things that struck me as I joined was that there is a bit of silo mentality, and that I just think that's tragic. And what I want to do is to use the Institute to pull together the absolute best that exists in this university to make really serious difference to world health outcomes. And I know we can do it. So that's why I've come here, because I don't think anywhere is a better place than Imperial to achieve this. And I have a great friend who's an adjunct at the business school called Sir Peter Williams, and who is my referee, and my other referee being Peter Rigby from the Wellcome Foundation. And the two of them said to me, you've just got to do this, Tom. It's the most exciting job you've ever been offered in your life. But not everybody will recognize that, but just have the faith it is. So I've spent the last 12 years of my life committed to giving people the choice of as good a life as possible at the end of life. As Cicely Saunders, the founder of the modern palliative care movement, said, how people die remains in the memory of those who live on. And it's terribly important that. So often I've seen families who I've spent time with saying that the whole journey, which might have been 3 years, was wonderful, but the last week was awful, and hence the whole journey was awful. And that's a sad fact for those clinicians involved in the earlier part of the journey, but all too often true. From my experience, I know, and so do you, that however well navigated the journey is, it is the end that counts. And in particular, that death. If it is not with dignity, then the experience of the rest of the journey is adulterated. All too often the outcome is a lottery, and historically was very much a lottery. But progress is really now being made, and it's the progress I want to talk about. On April the 1st, 2011, my wonderful mother died of heart failure. She'd lived for 2 years and managed to stay at home most of the time. She was an academic, and in a rather Victorian way, she took to her bed. And she had 2 brief admissions where she was brilliantly looked after in Cheltenham Hospital. At 11:30 a.m. on April Fool's Day, she went for a walk in her garden with my dear sister and died of a heart attack in the garden. My memories are entirely happy of my mother. She stares, when I shave, I have a photograph of her, and we have a bit of a chat every morning while I'm shaving. And my memories of her life, not her heart failure and not her death, they're of her life. In October 1982, our daughter died in St. Thomas's Hospital. I chose to forgive the state for the overwhelming failure to help two incredibly vulnerable 27-year-olds, and to understand instead that the state can only do so much, and sometimes we expect too much of it. But my daughter Emily gave me a wonderful and very precious legacy. I'm terrified of mice, but I have no embarrassment of death, no fear of death, and I have an absolute understanding that any of us in this room may die tomorrow. And hence, state and society together have to get it right, but it has to be state and society together for people, because death is the one area where you don't get a second chance. If a birth goes wrong, you can have a second chance, but with death, you never get it. Mike Richards, the great Mike Richards, in the end-of-life care strategy that he published in 2008, which I helped him write, said, "How we care for the dying is an indicator of how we care for all sick and vulnerable people. It is a measure of society as a whole, and it is a litmus test for health and social care services." Quick show of hands, I'm all for a bit of interaction. I'm going to give you the choice of 3 places to die: home, care home, or hospital. So where votes for home? Who would like to die at home? Right? Care home? Bad luck, girls. You have a 10-to-1 probability greater than the men of dying in a care home. Bad luck, boys. That's because they're going to live longer than you. Hospital? No votes. Hospice? Interesting. Yeah, okay. So how many are we in this room, Nicolette? 30? 31. Okay, so here's the bad news. You are all going to die in hospital. Okay. You only are going to die in hospice. And you're going to die in a care home or home, your usual place of residence, in other words. So, and by the way, you're very representative of far too many research surveys that have been done on this subject. It drives me mad the way researchers keep on doing the same research on the same subject. That's another story. So you're pretty representative of the world, but you're very 19th century. Sorry about that. In 1900, 85% of us died at home. Now 55% die in hospital, 25% at home, 25% in a care home, and 4% only in hospices. Bad luck if you live in London. Who lives in London? Right, bad luck. The 55% in hospital goes straight up to 64.7%. Anyone live in the southwest? Bad luck, move there quickly, because then you have a 1 in 2 chance. Death in hospital, 52.7%. Choose your disease very carefully. Whatever you do, die of cancer. Because 50% of cancer patients only die in hospital. Don't die of heart failure, because you're almost certainly going to end up dying in hospital. And if you have cancer, you're 4 times more likely to receive the benefit of hospice treatment. If you're not up for moving to Devon, then quickly get on the plane to Holland, where only 1 in 3 now die in hospital. And in this country, I'm afraid, and I'm ashamed to say it, you need to choose your county very, very carefully. 1 PCT last year spent, by the way, these are their returns. I still chair the government's end-of-life care board. 1 PCT last year spent 0.2 million on palliative care. The average was 3.1 million. And 1 PCT, which I think was Hull, spent 21 million. So vast inequities, depending on where you're based. So how pressing is this problem of end-of-life care? Well, it's both urgent and counterintuitive. The public assumes that medical advances, and by the way, public, I'm putting in brackets, please excuse me, Ara, politicians. Well, no, you got out of it, that's okay. The public and politicians assume that medical advance means less death. If you think about it, that is the natural assumption that most people make. Wrong. A very active time in the bedrooms of Western Europe in the 1950s, combined with medical advance, is leading to prolonged life and greater complications caused by comorbidity. And this is about to give society a huge challenge, not just here in Britain, but everywhere, which it simply doesn't have the courage to come to terms with. From 2016, the number of deaths in Britain will rise for the first time since 1960. So deaths have fallen every year since 1960. But now in 2016, they're set to rise. By 2030, the work of Irene Higginson at King's has shown we will need another 90,000 hospital beds simply to stand still in terms of coping with palliative care needs. We already spend £1.3 billion on admissions in the last year of life. Last year I published a review of palliative care for adults and children, which Andrew Lansley asked me to do with the wonderful Professor Sir Alan Craft, a fantastic guy. And what we showed there was that 429,000 people will need palliative care, but only 108,000 people are registered as dying. I'll come back to that. The single biggest problem we have is recognizing that people are dying. So what are the problems? Why isn't there a good death for everyone and a good life at the end of life? I'm going to go to 2008 first, and then I'm going to fast forward to 2012. 2008 was the year the strategy was published. Up till that time, palliative medicine was still viewed with suspicion, particularly by medics. It was very much regarded as a junior branch of medicine, but not by nurses. And you still see that, I quote from the recent Voices survey. Once we met the nurse was fantastic. Once he agreed the end-of-life care pathway, everything improved. So it's something that has rather sat with nurses more than it's sat with doctors. The reverse of that is the most unfortunate joke in the hospice literature, which is why they put screws in coffins, to which the answer is to keep the oncologists out. So it is reaching that understanding that someone is dying. And patients are not identified as dying, and hence they're unlikely to be treated or have their wishes discussed or recorded. The state failed to tell my family that my mother had heart failure. I've since discovered that the state knew and had known for 2 years, but no one had told her or us. And so we never got to have that conversation with my mother. And it's the only thing I regret about my mother's death is I never told her I loved her in the last week of her life. But I would love to have done that. By the way, one thing I've learned from my last 12 years, do tell people when they're dying how much they mean to you. Because if you don't, and they die before you expected them to, you'll never forgive yourself. Death can seem a failure to some clinicians, and I think oncologists have mainly got beyond this now. But Liam, with all respect, I think, actually maybe I've got that wrong, but cardiologists are still really struggling in this area, and actually getting cardiologists to accept they need to pass the patient over to the palliative care team is still a big problem in many of our acute hospitals. Little training and preparation for clinicians, even in the best of hospitals. I refer to my son Archie. When Archie was in Bedford Hospital 3 years ago, it was always he who was given the task of having the difficult conversation as an F1. And he talked to the Macmillan nurse and said, why is it that I'm always asked to have the difficult conversation? And the Macmillan nurse said, perhaps slightly kindly to his bosses, because you're the only one who's been trained to do it. So training has been a big issue. Support for families has been poor. Multiple sets of notes. I've been in patients' homes, in their rooms, where there are 4 different sets of notes from different visiting clinicians, and they often conflict, and they're often left there for the patient to read, and understandably to feel rather confused. Paramedics in 2008 on a 999 would take the patient in when there was absolutely nothing the hospital could do, and the patient was then stuck for an average of 15 days in a hospital, bed needed by somebody else, place the patient didn't want to be in the first place, and where no really relevant care could be provided. We'd become too professional. Palliative care had become the domain of specialist nurses and nurses. One of the first things I did at Marie Curie, which was extremely unpopular, was to begin to train up healthcare assistants to a very high standard. And Marie Curie nurses are now 80% healthcare assistants. And honestly, you couldn't tell the difference. Don't tell nurses I said that, but you really couldn't. Experience is what matters in end-of-life care, not just specialist training. In 2008, 54% of all NHS complaints were about end-of-life care. And Mike and I worked out that it could save the NHS £150 million a year if we could make a material difference to that level of complaints. There were no nice recommendations. It was the only medical condition, death, where there was no clear entitlement in terms of state provision. And that may sound odd, but it's true. And that's because we got in a muddle about what charity did and what the state did. So there was no understanding. There was no political ownership. Extraordinary, given that 5% of the population die during the life of every parliament. There is no other condition that 5% of the population will suffer during the life of a parliament. But politicians simply hadn't got it. And to his great credit, Gordon Brown got it and put another £250 million behind end-of-life care. With the wonderful remark, actually, I've just remembered I didn't record it. I'll tell you when. There was no clarity about strategy and no real ownership. Research was pitiful. Marie Curie was the world's leader in end-of-life care research across all disease groups. £5 million of funding. CRUK puts 450 million in to one disease every year, and in that year stopped providing research in end-of-life care. So we were really left alone with 1 or 2 universities. So a lot more research was needed, and there was no data. Then the strategy was formed. And that moment came from just a bit of courage, if you like, which is how I like to work, which is I got a group of people together in Lincolnshire. And I said, your home death rate is 19%. Let's get to 40%. And they said, it's not possible. You can't do this. It's just not possible. So I said, try me. And we got together all the services from across Lincolnshire. And 3 years later, evaluated by the King's Fund, we'd reached home death rate of 42% in Lincolnshire, saving them a significant sum of money by just putting in simple interventions and removing the barriers to the blinding obvious. As a direct result of that, the government then instructed Mike Richards to write an end-of-life care strategy because it became obvious that there was something that could be done. A senior MP from Lincolnshire said to me, I don't mind being quoted on this, it was one of the most wonderful moments in my career. He said, so if I get this right, Mr. Hughes-Hallett, you want more people to die at home? I said, yes, well, on the whole, that's where they want to die, and it's cheaper, and you know. And he looked at me and said, but what on earth will we do with all the bodies? And it was just a sort of seminal moment in my career, actually. So what did the strategies set out? Well, I'm not going to list it. There were 9 core streams, and they were the very obvious. They were what you would expect to see. But perhaps slightly radically, one of the key ones was an increased public awareness of dying. It was something that Mike and I felt terribly strongly about. Because once people were aware of it, they would talk about it, and then maybe we could begin to identify patients and get them on pathways. And vitally, and again this is something you'll get used to me, in me, is good value for money. I believe passionately that don't put an innovation forwards unless you are a genius, unless you actually think it's going to, in this climate, at worst be cost neutral and at best save money in the process. So how are we doing now in 2012? Well, we're doing pretty well, actually. We've now launched Dying Matters. This is one of their publications. It has 20,000 institutions signed up to it in Britain. And these are poems about dying. Over 100,000 hits monthly on their website, just trying to promote talk about dying. I went to Australia, which I believe is the country that does dying best in the world. So Kerala is always saluted too, but Australia really are good at it. And there they train taxi drivers and hairdressers, who are the 2 people most likely to talk to an individual about their mortality. Isn't it fascinating, isn't it? And they actually train them in having difficult conversations. They also have some unusual training. I went to see quite an elderly professor at Melbourne University who had a suitcase. She said, I've got to go now to see a group of patients in the hospice. And I said, what's in the suitcase? And she said, sex toys, without blinking. And I said, really? She said, yep, well, you like to keep them lively here, Tom. So the second piece of good news is that home death rates are rising for the first time in 50 years. So we've moved from 38%, which in 2008 was your usual residence, that's care home and home combined, and we're now up to 43%. most excitingly, because I am deeply anal, the electronic care plans that we dreamt about are now available. And in 8 sites, this is called the EPACS program. One of them is in London, being run by Julia Riley. But there are 8 dotted around the country. And basically what it does is it gives prognosis, end-of-life preference, and these can be, it's very simple, and it's accessible to all clinicians, including paramedics, 24/7. So if the call comes, the database is there in the ambulance, which says DNR, do not resuscitate, and whatever you do, please don't take me away from home. Leave me alone. My son may have dialed 999, but actually, I want to be here. And that is making an extraordinary difference. Already, fewer complaints, reduced number of unnecessary admissions, reduced number of ambulance journeys, improved clinician productivity, reduced number of times patients have to have difficult conversations. If you haven't worked with dying patients, the one thing they hate about the clinical and medical profession is that they never talk to them as human beings. It's always about the disease. And if you're dying, what you actually want to talk about is your children. Or, do you have children, doctor? But over and over again, it's tell me your story. The average dying patient is being cared for by 32 different professionals. The record we identified was in Edinburgh, some poor old bloke who had 96 people involved in his care pathway. Can you imagine what a nightmare? In London, Coordinate My Care, which the wonderful Julia Riley, together with Chi-Chi at University College Hospital, have driven. Now 51% of people are dying in their usual place of residence who have been part of this programme, and only 24% in hospital. And making a change in London, as you know well, is always harder than anywhere else in the country. In Salford, where they're also trialling this, 88% of people are now dying in care home or at home. And in South Essex, 70% have achieved their place of preference. The King's Fund launched their Enhanced Healing Environment programme, which many of you will be familiar with, and they've done a lot around end-of-life care, in particular mortuaries, so that people can go and visit patients after death. We were never offered that opportunity with our own daughter. And to give more privacy and dignity in the process. There are nice quality standards. Data mapping and peer group comparison. I'm so excited about this. But I have some bad news for you. So this was published yesterday. This is Mike and my end-of-life care strategy report. And for the first time, we now have mapped every single primary care trust in Britain. This was work done by Professor Julia Addington Hall at Southampton University, and it measures the patient's feedback through the bereaved relative under simple metrics around the quality of their care. Where do you live here?
Down central London near Tower Bridge.
Not good. Anyway, I'll tell you where to go and live. Basically, you want to live in Devon, Torbay, Plymouth, or Somerset, or north of Tyne. You get a bit far. You really don't want to live in London. You want to get out as fast as you can. I don't think that was a surprise to any of us, to be honest. And where you want, and you don't want to be in a commuter belt. So if you're in Hertfordshire, out, Berkshire, disaster area, So in terms of how patient, this is proper stuff. This is families saying what pain management was like. It's not wishy-washy stuff. It's genuine metrics seen through the eyes of the family. And of course, the feedback we're getting on this is focusing a lot of it around pain relief, because some got red scores on pain relief, and that's, for any clinician, that's not a nice thing to read. So that is now up and running and will be a very useful source of metrics. Better coordination. Marie Curie pioneered coordination centres in a number of places, so that when you've got 32 professionals, actually you go down to 1. And in our review, Alan Craft and I have now recommended that it should be a patient's entitlement, which must be funded by the state, to have a coordinator who coordinates their care. Because we want it to be cost neutral, we said this should not be a new professional, it should be a nominated professional who's actually chosen by the patient. Julia Riley, very interestingly, in her I'll talk about multidisciplinary teams in a moment, in her multidisciplinary team meetings, they are now run by either the patient or the GP who comes into hospital to run the MDT. It's quite interesting and radical, and is working. Broadening of the workforce, HCA is now included, and the other thing that we worked hard on was to make sure that dying sold cornflakes. So this was getting back to getting death out there into the public mind. So we were determined to capture a major organisation, and we could think of no better than Tesco's. So Marie Curie formed a partnership with Tesco's. It raised £6.5 million for Marie Curie. But more importantly, it got death and dying onto the back of lorries thundering up the M1. And now Lloyds Bank joined in, and then Nestle. So getting corporates now to talk about death and dying to help as well. What isn't working? Coordination, first and foremost. And I must tell you, and this may be uncomfortable for some of you, but in doing the research I did last year all over England, the constant enemy of the patient and the family is their least favourite phrase, the multidisciplinary team. They hate it. Because as far as they're concerned, it is an excuse for no one to have leadership. And they would also get extremely frustrated by the fact that they would see the doctor on Thursday and be told that the next multidisciplinary team meeting would not be for another week. So they couldn't give them a view on prognosis, pathway, or package before that meeting happened. 24/7 services are still extraordinarily patchy. People, strangely, don't die between 9 and 5 Monday to Friday. And unless you've got 24/7 services working well, the reality is the system will break and people will end up in hospital where they don't want to be. A doctor, this is a big minus, can admit a patient to hospital based on their skill and judgment. But to discharge a patient, they have to fill out a form which is 52 pages long. When my last PA's mum died in South London last year, she had to go and sit with the nurses to fill out the form because they couldn't work out how to do it themselves. And by the time the form had been filled out, her mother had died in hospital. So it was a fruitless task. So Alan and I recommended that end-of-life care must be free at the point of delivery in terms of both health and social care. And I'm absolutely thrilled that right at the back of the white paper on social care, there is a recommendation that end-of-life care will be free at the point of delivery for health and social care once it's been costed under the 10 pilots that are now underway. The other problem is the elephant in the room, and this is a nightmare, this elephant. I'm not expressing a view one way or another, but the constant talk about assisted dying is such a distraction to the actual underlying policy of improving health care at the end of life for all. And it's a serious problem. Every time you get a palliative care consultant on the radio, the first thing they talk to them about is euthanasia, not about how can we take forwards care for all. But overall, in less than a decade, we're talking about death. We've identified the main obstacles to a good death. We formed partnerships across all sectors, and all political parties included commitments to end-of-life care in their manifesto. What was the secret? Well, I think it was forming a team of partners from across disciplines, defining and recognising the problem, then convincing clinicians and policymakers that there was a problem, researching where the barriers were, and then dismantling them one by one, with the patient and family voice constantly used as the trumpet call whenever positions got sticky or positions got entrenched, and then crucially producing and disseminating evaluations and findings to spread success. But, and Aaron knows I'm passionate about this, but making change first and having the courage to do so, rather than stalling innovation until evidence was available to justify it. And that is my big bugbear around health innovation. In almost any other field, people will take risk. And very understandably, the regulations that we're surrounded with actually work against us taking the risks that we need to take. Crucially, building the economic case that's unarguable, and then finally, never, ever giving up. Because there were some bad moments in this journey too, but as long as we constantly kept the patient in mind, it was okay. Cicely Saunders said right at the end of her life, "You matter because you are, and you matter to the end of your life. We will do all we can to not only help you die peacefully, but also to live until you die." So 3 things are going to happen this year that will take that forward. The first is a new campaign that's just been launched yesterday called Find Your 1%. which is going out to all GPs saying, find the 1% of your patients who are going to die in the next 12 months. Think about it, get them onto the palliative care register. I think I'm going to leave the rest in the interest of time, actually. I'm just going to give you 3 quotes by way of conclusion. See if you can guess who the first 2 are, and I'll tell you who the third one is. So, nothing in life is to be feared, it is only to be understood. And this is about IGHI, as far as I'm concerned. Nothing in life is to be feared, it is only to be understood. Now is the time to understand more, so that we may fear less. Anyone know who said that? Who said that? Top of the class. And this one I love. I'm going to have it written on my wall. Life is not easy for any of us, but what of that? We must have a perseverance and above all confidence in ourselves. We must believe that we're gifted for something and that this thing must be attained. Anyone know who said that? Stick with your last. It's Marie Curie again. And then finally, a very short quote, which is made up of 2 people I respect greatly. And this could be the mission for the Institute. Translating discovery into care. That was said by a man called Darcy. And the other comes from the new president of FIGO, who Leslie and I were talking about earlier, the Greater Rule. The real challenge is implemental. Not what to do, but how to do it. And I so subscribe to that, actually. So finally, here in the UK, we genuinely lead the world in end-of-life care. We really do. We're the very best at it. Elsewhere, problems are more severe, ranging from the US's insistence on continuing to assault the patient with treatment until the very last second. And if you have time, Google Bill Keller's article in the New York Times last week, which is about how his father-in-law, was treated at James Paget Hospital in Suffolk on the Liverpool Care Pathway. And he thought it was wonderful. Went home, talked to Professor Emanuel, a great expert in palliative care in America, and said, what chance of this happening in America? To which the reply was 0. Or into the developing world, where we have this embarrassing absence of opioids, making a painless death a dream and not a reality. I'm ashamed to say that 85% of the world's opioids are supplied to less than 10% of those who need them. So IGHI has some work to do and intends to form an end-of-life care forum to further the needs of patients and families around the world. And if any of you would like to use your skills to help us build this forum, we would welcome your support. It's probably time we have some lunch, so thank you.